calcium changes in mouse hearts mediated by fibroblast growth factor 23 and its implications for chronic kidney disease. Fibroblast growth factor 23, or FGF23, has been shown by our lab to directly increase muscle contractility and increase calcium in isolated ventricular cardiomyocytes. Studying calcium is important because acute increases can lead to cardiac arrhythmias and chronic pathological heart remodeling. Furthermore, clinical studies have demonstrated a relationship between levels of FGF23 and atrial and ventricular arrhythmias. On top of that, our lab has shown that in vivo injections of FGF23 induce ventricular arrhythmias in anesthetized mice. And you can see this clearly in figure 1, where injection of FGF23 into an in vivo mouse heart leads to EKG arrhythmias seen in premature ventricular contractions and PVCs in bigeminy. These arrhythmias are then resolved by treating the mouse heart with an anti-FGFR4 blocking antibody, which blocks the receptor for FGF23 in the heart. This leaves us with two things that remain unexplored. One being, does FGF23 increase calcium in an intact ventricular muscle? And is this calcium response in the arrhythmias mediated by a specific receptor? So we hypothesized that pathological levels of FGF23 will cause an increase in intracellular calcium in ventricular myocytes, which are mediated by the fibroblast growth factor 4 receptor in the heart. To study this, we harvested mice hearts, cutting them into 2 millimeter ventricular samples, treating them with fluo-8, a calcium-sensitive dye, and Ringer solution prior to imaging. Then samples were placed under an epifluorescent microscope and continuously perfused at the following intervals: a 5-minute baseline, then followed by either vehicle or FGF23 perfusion for 7 minutes, and then lastly a perfusion of positive control with potassium chloride for maximum calcium response from ventricular muscle. Next, to determine the contribution of FGFR4 to the augmentation of intracellular calcium, we pre-treated ventricular muscles with FGFR4 specific blocking antibody and repeated the previous steps. We measured the changes as a percentage of KCl response, as it represents the maximum calcium response induced by ventricular muscle strips, and statistical analysis was done using a one-way ANOVA with done at post hoc analysis. This brings us to our results in figure 2, where you can see the representative pseudo-colored fluo-8 fluorescent images of left ventricular muscle strips. Now, the warmer the color on the muscle strip means the more calcium is present, and you can see the changes from figures A, B, and C from baseline to FGF23 to KCl perfusion, where each one has an increase in the amount of calcium respectively. This is all summarized well by figure 2D, where you can see this all as a representation of percentage of KCl response, where FGF23 perfusion has a significant portion of KCl response in comparison to the blocking antibody and the vehicle treatment, meaning that FGF23 perfusion into the heart induces calcium response. So in previous studies, we have shown that pathological levels of FGF23 induces arrhythmias, whether it's premature ventricular contractions or prolonged QTc intervals. This experiment demonstrated that perfusion of FGF23 at pathological levels induces a significant increase in calcium in intact ventricular muscle. Furthermore, when these ventricular samples were pre-treated with an anti-FGFR4 antibody, there showed no increase in calcium response following FGF23 perfusion. This provides a mechanistic relationship between FGF23 and induced arrhythmias through an increased amount of calcium. So in future experiments, it'll be important to study second messengers along the FGFR4 transduction pathway, whether it's phospholipase C or inositol triphosphate, to determine future treatments for FGF23 induced arrhythmias and pathological heart remodeling. Limitations in our study include that these were young and disease-free mice, that FGF23 was provided in a pulse dose manner rather than a chronic setting like many CKD or end-stage renal disease patients, and that while we use concentrations of FGF23 found in patients with end-stage renal disease, it's difficult to know the exact concentration reaching the myocytes. And these are our references and sources of funding. Thank you.